All right, so we're looking at chapter 13. This is a very small chapter, actually, and it's going to be all about concepts of injury prevention. So we are looking at, basically some very common injuries that are associated with like athletics and sports. So this is actually going to kind of dive in kind of specifically to some of the sports stuff here. And you can kind of tell we're kind of wrapping this class up in the concepts of overall like program design, right? So today we're looking at injury prevention. We're going to get together tomorrow. This is going to be our last chapter, by the way. We're going to get together tomorrow, and then we'll have our final exam on Thursday, which will be kind of fun. It'll be the last day of the year. Which will be a blast because we're all heading to winter break after that. And but looking at our last PowerPoint, we've talked a lot about like how to write effective programs for improving athleticism or just getting a really great workout in. Easy to follow, well organized stuff. But now we're gonna kind of look at like how to write a program for somebody who like might be experiencing some type of injury. Now we're not physical therapists, right? That's something to always keep in mind. We're not applying treatment for any of these conditions, but we do know that like a lot of these injuries are non-contact injuries. And if it's a non-contact injury, I always think that's a big fancy way of saying totally preventable injury, something that really shouldn't have happened, but it did happen because your body is maybe in a resting position it shouldn't be resting in, or it's working in a direction that it really shouldn't be. It's recruiting muscles in the wrong way, little things like that. And that's kind of what leads to these overuse injuries. So our objectives for today are to kind of understand like the frequency of injury, sort of where that happens, the mechanisms that cause it, some of the risk factors, which really is the risk factors is the big one, like that's where we're looking at alterations in posture. The reason we started this whole module with so much information about assessments, pronation distortion syndrome, lower cross syndrome, upper cross syndrome. The reason we talk so much about that stuff is because those types of posture lead to very common overuse injuries. And so today we're going to kind of dive back into like how to address those things. And so in the end, we'll start to incorporate different exercises to kind of decrease that injury risk. So obviously very specific injuries, athletics, there's the number one thing that every athlete's trying to avoid, some type of specific acute injury. And so, when you hear about like, that's what takes you out of the season. And, it makes sense in athletes because they're working really, really hard, playing like whatever, specific sport that is they're playing. And, they're trying to be at like peak performance, which means they're working hard, they're training hard, they're not really getting an adequate amount of rest. I mean, look at baseball players, they play 1 million games a season, and so like there are a lot of like kind of problematic injuries that occur with like that overusing of the body. And so there's a lot of factors that can kind of occur to this, but the more likely you are the more you can have your body in a good posture, the less likely you are to kind of deal with some of these injuries. And so what we need to do is we need to develop a program that has like, develop an effective strategy to prevent that injury. And, let's say your client did experience an injury and they go to the physical therapist and they, rehab the whole thing. Well, then we need to recondition our athlete. We got to make sure that that injury doesn't come back. So I always like to think of like physical therapists as rehabilitators. Their job is to rehabilitate something that's broken. Our job as personal trainers, we are prehabilitators. Our job is to prevent something from getting broken or maybe getting broken again, So looking at this first one here, sort of looking at the epidemiology, which means just like how often, it's the epidemic of things, right? The study of how often these injuries occur. We're looking at like foot injuries, right? So looking at the foot injuries, there's a lot of overuse injuries that can occur here. Achilles tendonitis is one. That's 2.8% of all like foot cases. Plantar fasciitis, which is a very common one, 3.7% of all cases. Stress fractures on like the overall like bottom of the foot, that's 9% of overall cases. So all of those, right, are going to be kind of be caused by the same thing, which is really just like, moving the wrong way or improper posture. And so our biggest at-risk populations that we're going to see are people who do not have proper flexibility and strength in the foot, right? So what are these injuries, right? Achilles tendonitis. Whenever you see the word itis, I want you guys to think inflammation. That's what it means. Actually, I'm pretty sure that's exactly what it means. Itis, word origin. What's the etymology? That doesn't have any definition. There we go. Yeah, forming the name of inflammatory diseases. Use the reference of the tendency of state of mind compared to what? Well, anyway, yeah, itis is going to be associated with any inflammatory disease. So when you hear about gastritis, that's inflammation of the stomach lining. Tendinitis is inflammation of a tendon. So Achilles tendonitis is inflammation of your Achilles tendon. So if I look at like Achilles tendinitis, right, what you'll see is this kind of achy, painful sensation like right back here, right? And it's very commonly associated with, you guessed it, overpronation of the foot, or maybe possibly over supination of the foot and ankle complex. But this big inflammation here, and so it gets kind of stiff and painful. It can sometimes cause bone spurs. It can cause like a lot of like injuries, and so that's definitely something that we sort of want to address through like looking at someone's foot and ankle posture and determining like whether or not they are sort of moving the way they're not supposed to. Plantar fasciitis, that's inflammation of the plantar fascia. So plantar fasciitis here. Very similar, actually. In fact, you'll notice that your plantar fascia and your Achilles tendon kind of share like a common through line there. So often these two are actually associated with each other. You might get one, or you might get the other, or you might get both. But this is like a painful, what you'll hear people say is it's like a stabbing sensation at their heel. It's much worse in the morning. A lot of times people will like describe plantar fasciitis being way, way worse in the morning. It's like their first couple steps in the morning are extremely painful. And then, it kind of gets warmed up, and then that allows it to kind of relax a little bit. And then they'll sit for a little while and it'll stiffen back up. And then when they start walking again, it's really painful for those first few steps. It's ironic, but plantar fasciitis sort of feels better the more you get going. And that like leads to, decreased inflammation because like the whole area just kind of warms up and the muscle sort of relaxes a little bit. Then we have stress fracture. So looking at like your, looking at your foot and like what bones you've got, right? So actually, oh, come on. Freaking shopping thing. There we go. I liked the color one. There we go. That's better. So when you look at like the bones of your foot and ankle complex, right? So you've got all of these like little cuboid bones here that are in like the top part of your ankle, right? So those are like your ankle proper, right? All these like little cuboids, these square shaped, square bones. That is, like I said, those are what are called your tarsals, right? And then you've got these long bones that make up the bridge of your foot. Those are what we call your metatarsals. So these square-shaped bones are the tarsals. In the same way that in your wrist, you've got your carpals, which are, the little tiny bones, little square bones that make up your wrist. And then your palm is made up of your metacarpals. So you've got your tarsals and your metatarsals here. And then each of the individual little like toes, those are what we would just call your phalanges. And we use the same term in the fingers. These are your phalanges. They're your digits, that's what I like to call them, digits or phalanges, if you want to call them whatever. But what we'll see is we see a lot of like metatarsal stress fracture. And, it's not like their foot got, you didn't drop like a dumbbell on their foot or anything like that. You didn't like, have a car run over the foot. This literally, you were running and running and running and running, and all of a sudden, you know, you just experience like a stress fracture. Because like when you think about it, like your weight, your body weight is coming down 2 to 3 times what you weigh is hitting the ground every time you are like taking a step. And when you're running, like that's even, you know, that's multiplied even greater. And so like if you've got a really stiff foot and it's not moving, you know, with proper flexibility, the muscles aren't recruiting, you know, you've got all this stress coming down on this little tiny bone, and it literally is as if you hit the freaking thing with a hammer and it just broke, you know. It's like if I try to walk on like a pencil and I just put too much pressure on it and snapped the darn thing, you know. And that is what we see in a lot of like stress fractures. So very, very common there. Again, often associated with overpronation and oversupination of the foot or a lack of flexibility. And so, you know, our big thing here, and this is what's kind of funny about this chapter, you're going to see foot injury prevention. You know, what is our treatment for something like this? Well, we want to ensure proper range of motion, which means we want to have proper flexibility of the foot, and we want to strengthen the appropriate muscles. And that's really going to be our answer to basically every injury, you know. Like I'm spending a lot of time on this first part here, but because it's our first one. But when it comes to like looking at a lot of injuries, that's what we spend most of our time doing. We stretch what is overactive and we strengthen what's underactive so that we can you know, allow this proper flexibility to exist while allowing like these muscles to take some of the weight off of these movements, you know, and so that we can move how we're designed to. So we need proper extensibility, particularly of the calf muscles. So a lot of times, like a big part of this is experiencing like way too much plantar flexion. Our plantar flexor muscles tend to be a little overactive. That's going to be your soleus and your gastrocnemius, right? And you know, maybe it's one side of the gastrocnemius compared to the other. Maybe it's the lateral side, and then the medial is actually underactive, and so that's causing external rotation of the foot. But that's a big part of it, right? We need to look at like how do we stretch out our calf muscles? You know, how do we do all those calf stretches that we talked about and restore that proper ankle mobility? And then we see proper strengthening of, maybe it's actually the calf muscles, right? Like that's kind of weird. We see it on like both lists here. It's like, you know, we need to lengthen this, but we also sometimes need to stretch it, strengthen it as well. Well, yeah, that actually does make sense, especially when you think about like if you're using the outside part of your calf too much and the inside part of your calf not enough, you know, well, what we can do is we can apply like a good stretch to that outer part of the calf. Then when we go do like, let's say like calf raises, right? Just classic, you know, regular old like, you know, calf raises. Well, if you turned the outside off, now the inside calf, your medial calf, gets a chance to actually do the work that it's supposed to. So you don't necessarily need to target it specifically. Maybe it just needed the ability to kind of catch up, but that other muscle was so overactive that it was the only one that was firing whenever you're doing calf steps. And so rather than just doing a toe raise like this, every time you contracted, you would probably turn a little bit like that. You'd do this external rotation because the lateral calf does a little bit of that as well. The anterior tibialis is a really big one that we often need to strengthen. Remember, your anterior tibialis is this muscle, this big muscle right on the front of the shin here, right? It runs right from the top, right from the bottom of your knee all the way down, and its job is to perform ankle dorsiflexion, right? So its job is to pull your toes towards you, and we see a lot of people who just do not have very good dorsiflexion. My roommate's a really good example of this. I always make fun of him, but he's got like just huge calf muscles. And so like, and he'll walk around on the like the toe on his toes and only on his toes. And I'm always just like, I'm like, heel to toe, Seth. like walking heel to toe, buddy. Because I'm just trying to get him to strengthen that anterior tibialis. And it would help so much with like range of motion and stuff. And it's a big deal, you know, it's too much plantar flexion, not enough dorsiflexion. So again, we need to stretch those calf muscles, and, you know, we need to strengthen those tibialis muscles. And then another one big here is the toe flexors. So your toe flexors are, you know, part of these part of these, they wrap around the bottom of your foot here, and then they grab and they pull your toes this way. And we do want those muscles to be strong. I know it doesn't seem like we want to spend a lot of our time in the gym doing toe reps, but stretching these, what are called your flexor hallucis, and then there's like longus and brevis and stuff. But stretching these toe flexor muscles are a big part of like strengthening the bottom of your foot. And so, it'll come down to doing things like towel scrunches, which is literally an exercise where you stand on the floor and you scrunch up a towel, and then you do your toe extensors as well. You'll often like flatten it back out, and so you'll scrunch it up and you'll flatten it back out. And that's actually like a big part of like strengthening the bottom of your foot. I know it doesn't seem like it is something that's like hugely important. And it seems like it'd be silly for us to spend time in the gym like working on this. And yeah, maybe it is. Like, you don't necessarily have to do this with your clients during their session, but if you can teach them how to do this and adopt this in their home life, that can really, really help with them. If they've got this injury, it's like, all right, look, I'm not going to make you spend time lifting up a towel in the gym and placing it back down with your foot. But if you can spend a little bit of time doing this on your own, it really is going to help with like plantar fasciitis, Achilles tendonitis. If you're coming back from a stress fracture, all of those things. We want to keep those injuries from coming back. You hear about people with plantar fasciitis, and it's a nagging injury they just deal with for years. They just complain about it for years and years and years. And it's like, why deal with it for years? Why not like do this silly thing? Take the time to do your physical therapy and fix it. Other versions of that, by the way, you can also like, and like one thing that I'll do, because I find that like people have a hard time doing it if it's not fun or difficult enough. I like to turn it into a balance exercise. So I'll have somebody lose their shoe, lose their sock, and then stand, and now it suddenly becomes like a balance stabilization exercise. They're gonna stand I'm gonna stand on my left leg, and with my right leg, I'm gonna reach down, grab that towel, and lift it up, hold it for a second, and then place it back down, lift it up, hold it for a second, and place it back down. I'm not moving my balance leg. I'm getting like balance in. So now I've turned this into like a fun dynamic movement. Maybe that's a little bit more, effective at getting my client, back into that proper posture. But really, ankle mobility is absolutely huge. That is often going to lead to some of these foot injuries. And it travels up, by the way, like plantar fasciitis also is commonly associated with like a little bit of like hip tightness and things like that as well. It's all that fascia, forms these big long lines, and it's all connected and stuff. So, it's pretty common that this stuff gets, all associated together. In fact, you can kind of see it here, right? You can see where this person's working on like doing a calf stretch. They're stretching out their plantar fascia by kind of flexing out their feet. They're massaging. This is a very weird order to do these things in. They're doing an Achilles stretch, a frozen can roll. This is actually a really big one. I don't know about a frozen can, because if you freeze a can, it'll probably explode. But a frozen water bottle is a very common one. Put a water bottle in and you literally just roll it. Or and then here is like another calf stretch, right? She's performing dorsiflexion, so that's stretching out those plantar flexors. Very weird order, this drawing in. It should be the massage, then do the plantar fascia, then do probably the standing calf, Achilles, and then towel is the order I would do it in. The stretches don't really matter. So you definitely want to do the massage first. And then anyway, so those are some really common ways to sort of work on, if you got a client with plantar fasciitis, if you got a client with, stress fractures, those are some things that you can do. So we're going to go ahead and apply that same logic to the rest of these injuries. Looking at ankle sprains, right? Ankle sprains, the most common sports-related injury. This is so very common. It's also the number one thing that results in like time lost. This is sort of when you think about like athletes don't get to play in a season or something. This is the most common thing that results in that. Lateral ankle injuries are the most common of all ankle sprains. They have a very high re-injury rate because what ends up happening is, that ligament gets torn and then, slowly tries to repair itself, but you have a lot of scar tissue in the area. You end up losing a little bit of glute strength because you spend all this time hobbling around and you're not performing hip extension the way you're supposed to. So it has a lot of like long-term consequences. Guess what? That reduced hip strength is going to lead to pronation distortion. That pronation distortion is going to lead to, you guessed it, ankle injuries. So lateral ankle sprains, right? I'm going to go ahead and pull up a picture of this. What we're talking about is we are looking at where someone excessively inverts their foot. They do it way too much, and then that results in this little ligament that holds your fibula to your ankle. It tears it. So this, like what's called your CFL ligament, that's your calcaneofibular ligament, or sometimes it'll be this posterior one here, but fairly rarely. We'll see it like this, like little sprain right here. And so there's a couple different grades. I like this. This is great. There's like a grade 1 sprain, which is sort of just like you overstretch it, and so it experiences these little micro tears. It's where it feels kind of tender. Grade 2 strain is where you can see like an actual like tearing in the tissue. So if they were to do an MRI, they'll actually notice that it is certain fibers of it are detached, but you didn't fully detach it. And then a grade 3 sprain is like a full on, complete tear. And this usually requires surgery to fix because they need to reattach that so that your, immune system can actually fix it. And so what they'll often do is they'll basically do a little bit of super glue in there and it'll kind of reattach it and give your body time to fix the whole area. So that's a lateral ankle sprain. There's also medial ankle sprains, which can happen on the opposite side. These are really, really rare. But your medial ankle sprains will often happen with excessive eversion of the foot. And so what's called your deltoid ligament here will get torn. Same concept. You can see like there's that, there's your CFL that we just talked about, right? There's your deltoid ligament. Both of these can get torn. This one's really uncommon. This is where somebody, they would cave in so much and they would roll their ankle. The bottom of the foot would show this way. It's just not a very common movement that happens. Most people tend to, spend a lot of time in eversion. So many people have like pronation distortion syndrome, right? Which is where we see that excessive eversion of the foot already. And so because people are so used to being in this position, this is fairly mobile. This ligament is used to being stretched out. So because it's so used to being stretched out, it's just not very common that it gets overstretched. That's actually why this, people spend a lot of time in this posture that we're seeing in this picture here, which is what causes this ligament to be so like tightened and shortened up. And that's what really causes it to tear in the end. So, that's your medial ankle sprain. And then we've got high ankle sprains. Which are, they're going to happen much higher. No, that's not the picture I want. Come on, just show me the freaking ligaments. There we go. So you'll see like high ankle sprains. It's not quite got the one I'm looking for, but you'll sometimes see it's this one here or this little ligament that attaches like right here from your tibia. And so high ankle sprains, not quite as common. Usually it happens, there it is. It usually happens during like a tackle or something. Someone will grab it and you can see they're just going to cause this massive like dropping, or sometimes even if you like pull it too far this way, both of those can result in like ankle sprains. And like they're pretty friggin', this is the one that apparently is most painful. I mean, all ankle sprains are going to hurt, but like this one is just, it's a kind of a thicker ligament, so it kind of just hurts a lot more. But it often involves like a little bit of rotation while also like dropping that foot down. So sports that involve like a lot of cutting, sports that involve tackling, or even wearing like super rigid boots, what ends up happening is like your foot and your foot all stays together in your ankle complex. It's all like stuck, and because it's all stuck when you like turn, you just end up pulling it. And it's like your shin bones are like, no, we're attached to the thigh, and the thigh's attached to the glute. Like we're not rotating. So then your foot over rotates and just tears that. So how the heck do we deal with this, right? If we see all these ankle, if we see like these are the very common injuries, again, you're just going to hear me repeat this concept a lot today. Well, if we want to prevent this injury, we want to prevent it from coming back, we need to ensure proper range of motion of the area that we're talking about. In this case, it would be the foot and ankle complex, right? So we need to have proper dorsiflexion, which a lot of people don't have. We need to have good balance as well. Like balance is going to help with our range of motion. I know that like we don't commonly associate the concept of balance with like range of motion and stuff, but like having proper balance is going to be key, because again, that gives you proprioception, and proprioception tells your brain what muscles to recruit and what muscles to relax when it's supposed to. So that gives you that neuromuscular efficiency. So we need to have good balance there, and then strengthening of your dorsiflexors and your inverters, right? Which is going to be your anterior and your posterior tibialis. So it seems kind of silly, but again, like a really great exercise to work on. Let's strengthen the anterior tibia. I like it. I want the band one. There we go. So here we got Brent Brookbush. He's my favorite physical therapist on YouTube. Huge fan of this guy. Double ads.
Exercise. I'm gonna have my friend.
However, Brent Brookbush videos are always quite lengthy, so we're gonna skip forward.
Those muscles that become synergistically dominant when this muscle becomes inhibited. So we have the tibial, right? And what you can do is actually foot up and in, toes curl. We did make another video.
Oh my God.
When I'm treating, I'm
looking at the preview here. Does she ever move her freaking ankle? Do the movement. Okay, there we go. It's right there. Wait, sort of.
Probably elevate the heel on something like a foam roll, because if you don't have just a little bit of a downward angle on this band, it tends to flop off the foot every time you go into this plantar flex relaxed state of this exercise. Now let's talk about activation exercise in general. We need to figure out what joint exercises.
Okay, that sucked. Let's find, there we go. So he's gonna have the band wrapped around his foot. There we go, thank God. And what he's gonna do is he's going to pull it up towards him, right? So he's doing resisted dorsiflexion. So he's performing dorsiflexion, but this band is pulling against him. There's a really good point in the other video, right? They talk about doing a little bit of a downward. It doesn't change like the way it pulls. It just means that like you're not gonna have this like slide off your foot quite as easily. You can kind of see like he's not even going into full plantar flexion, because if he does, that band is gonna go snapping off of here. And that's not going to look good for this commercial that where they're trying to sell these bands. So what does help is actually doing this sometimes up on a table, and instead of going like straight away like this, pulling slightly down, or you as the trainer would literally hold on to the loop and hold it at like an ever so slight downward angle. But that's resisted dorsiflexion. That's going to be really great for the anterior tibialis. But if we look at the posterior tibialis, it's very, 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 very similar, except instead you're going to pull at an angle and you're going to have your client do a scoop inward. So it's going to look like this instead. So she's going to hold it at an angle like that. And she's already kind of like doing this. She's doing an isometric here. So she starts neutral. She's holding it to the side, and she is going to invert her foot, right? And internally rotate. So she is supinating the foot, and then she's allowing it back to neutral. And then she's going to have her do a big long isometric here, I think, in this protocol. I'm not a big fan of these super big long isometric versions for activation techniques. I like, 3 to 4 seconds personally. But you can see like she's doing kind of these, I think she does this big long one in a second where she really holds for a long time. So that's your posterior tibialis, right? So both of those, that's your anterior and your posterior tibialis. Anterior is straight on, posterior is side to side. And that's a really good strengthening movement if you have a client who's coming back from an ankle injury, especially in particular, the lateral ankle injury, the lateral ankle sprain, which again is most common, those two are going to be absolutely key. And then lots of balance exercises, because again, look at like how much work your foot does when you balance. I mean, I freaking demo balance exercises all the time. And yet standing on one leg, you can see, actually, I can get a little closer. You guys can see better. That's the bottom of the foot right there. So you can kind of see, like, you know, look at how much like little bits of work your balance are doing. You know, if I move my hip a little bit, you know, that's my bottom of my foot does all these little squeezes. And those squeezes are really what give you, they're what give you a lot of this like strength in your tibialis and your calf muscles, you know. Strengthen the bottom of your foot, give you ankle proprioception. They teach you how to move the right way, so you're less likely to deal with that injury again. So that's the foot and ankle complex. You guys have any questions about foot and ankle? Bet you didn't know we'd spend, when you got into training, you'd spend so much time working with feet. It's a very, very freaking common thing. What's his name? Quentin Tarantino should have been a personal trainer. That guy's obsessed with feet. I say that. Now, next time you watch a Quentin Tarantino, you wait. There will be some moment in there with like time spent. It's weird. It's weird. All right. Look at the knee injuries. Let's look at the knee stuff. So moving up the body, we go to the knee. Very common injuries that we're going to see here are ACL tears. In particular, I mean, obviously you can tear any of the ligaments in your knee. You know, if we look at like all of the ligaments of the knee, knee ligaments. There we go. That's great. So you can see this would be like, you know, there's the outside of the knee there, right? So that's your outside because that's your fibula, right? So we're looking at the front of the knee. I know you don't see the kneecap here. They've removed the kneecap to make this easier to see, but normally your kneecap would be right here. And what you would see, this is your anterior cruciate ligament. This is your posterior cruciate ligament. So that's your ACL and your PCL, and they cross each other. That's where we get the term cruciate for crucifix. So the anterior cruciate ligament's the one in the front, posterior cruciate ligament's the one in the back, anterior for front, posterior for back, cruciate for cross, ligament because it's attaching bone to bone. Then you can see these little like discs underneath both of these major like condyles here, right? You can see those are what we call your meniscus. These aren't the best meniscus drawing. Your meniscus is a little bit better. They look like these little C-shaped. Actually, this is a great picture. I'm gonna pull this one up. There's your ACL, there's your PCL in the back. But you can see these little C-shaped discs that kind of lay on the top of the knee there, right? And what they do is that like allows you to obviously prevent friction, so this bone's not grinding on this bone here as it's resting. But it's also like keeping it from dislocating on either side, because it's really both of your meniscus are really thick on the outside and they get thinner as they come to the middle. So that kind of creates like a half pipe situation, which keeps your knee locked in. And then you can see like on the outside, you've got your LCL ligament. That's your lateral collateral ligament. Lateral because it's on the outside, and its job is to attach your femur to your fibula. And then you've got your MCL, that's your medial collateral ligament, and that's job is to attach your femur to your tibia. And so you've got these two ligaments on the outside here, which are like holding everything, you know, laterally. And then you've got the cruciates, which are holding whenever you perform twisting movements. So common injuries that we tend to see, we often see LCL injuries, which are fairly common. But the biggest, most common one is that ACL. Oh, and then there's your kneecap in the way there. ACL is definitely the most common that we see. PCL is pretty rare. You often have to hyperextend your knee to do that, which just doesn't happen very often in most sports. You have to hyperextend it while twisting, which it just isn't a very common motion that occurs. And then same thing with an MCL tear. Fairly rare for this to happen because you have to get hit from the side and then overextend this, like the lower portion of your leg this way. Like you have to push it, you know, you would have to tackle me from left to right and hit me below the knee like this and cause that to happen. Which if you're going to hit me from the side, you're going to hit this leg first. So it's a fairly rare injury because it just doesn't occur very often. But we often see people get hit from the side this way, and then they go like this, and that overstretches. So, these are some pretty common, some of them are common, some of them are less common. The most common is definitely the ACL, and that's where someone will plant and they'll twist, and that twisting is what causes that ligament to detach. So very expensive, very time costly. Like this is pretty annoying when this happens. It takes a very long time to come back. Often requires surgery. It's very rare that an ACL injury is only. It's pretty rare that it's only a minor tear. Meniscus tears, that's another one that they often have to go in and like reattach. Your meniscus, when it tears, let me show you what that looks like. Yeah, that's another one that happens a lot during cutting. There's a couple different versions. There's a bucket tear, and they call it a bucket handle tear because it kind of looks like you can slide your hand in there and carry it like a bucket, where it's still attached on these two sides, but then it's not attached anywhere back here. But basically you'll have all these like different types of tears. And what they have to do is they have to go in there and kind of repair it. Because what's going to then happen is you're going to have like a lack of stability in this part of the knee. It's actually pretty easy. Honestly, a lot of times they go in there arthroscopically, and they just kind of, like I said, like super glue the whole thing back together. I keep saying super glue. Obviously, it's not actually super glue, but it's kind of like surgery super glue. According to every surgeon I've ever talked to, they're like, man, it's kind of like how you super glue stuff together. And I'm like, surgeons are so weird. They're like mechanics that get to work on our body. Surgeon, it's such a weird concept to me because it's like, like even just like sewing something up, like if you're just like giving somebody stitches, I'm like, you're basically taking like human skin, sewing it together the same way that like my mom would patch my jeans when I was a kid. Anyway, I think it's weird. So the biggest mechanisms that we're going to see that, oh, wait, actually, sorry. So those are our two common like tears, right? ACL or any of the ligament tears, meniscus tears. Now, there are a couple other common injuries that we see in the knee area. One of them is just general patellofemoral pain. So when I say patellofemoral pain, I'm saying it's part of your patella, that's your kneecap, and the femur, that's your femur, right? So you're having pain where your kneecap meets your knees. And so this is often caused by poor patellar tracking. What you'll see is like the kneecap will either grind, as it's like, it's supposed to be able to travel up this condyle. Like if we look at like patellar femoral motion, give me a GIF, hook me up. Oh, wait, that's going to be improper motion. So here we go. This is what's supposed to happen to your kneecap. It's supposed to slide and glide in this little groove here, right? There's another one. Is that a GIF? No. So it's supposed to, allow this whole like movement to occur. But unfortunately, like if you have like overactive muscles that are pulling the wrong way, actually that first one that I pulled up, we see a weak VMO and a tight, oh God, it's the worst to say, lateral retiniculum. Nope, that's not right either. I'm adding an extra J. Retiniculum. That's what it is. It's so hard to, I punch words too hard in the beginning, and if it's too long, I can't say them. But anyway, you see like tightness in the vastus lateralis, and a weakness in the vastus medialis oblique. So you've got too much strength on one side of your quadriceps and not enough on the other. And what'll happen is that patella, this GIF actually isn't showing it, but it'll track the wrong way. It'll move in that groove improperly. Poor patellar tracking GIF. There we go. Oh, I think so. I think this is the same. I think it's just more of the same. Oh my God, it's literally, do you guys see how it flashes a last little thing at the end? That's the part of the GIF I want to get to. So in this picture here, you can kind of see it off to the side here. See the tilt or the glide, right? You can see it. I'm going to kind of zoom in here. It'll basically not slide in this groove the way it's supposed to. It'll either be way too far tilted or it'll be way too like tilted off, like glided off to the side. So that'll be poor patellar tracking, you know? It'll move into one side, it'll move to the other. It can go in all the directions, by the way. You can actually see poor patellar tracking in any direction. Doesn't just have to be left or right. It can be up to the side. It can be too elevated. It can be too depressed. All of those are really bad. And that's just going to be caused by like often tight quadriceps muscles. Another one that we're going to see is runner's knee. Runner's knee is part of a problem that's actually being caused at the hip, but it's being caused by that tight IT band. And so runner's knee is right along the outside of the knee, where you'll see like a lot of like friction and a lot of pain, like right off to the side here, and they'll get a rubbing sensation. I had this when I was in high school, actually, when I ran cross country because I never stretched after class. But like what'll often happen is you'll get like a rubbing sensation like right out here, and it'll be extremely, extremely painful. That's being caused by a tight IT band, you know, that's traveling all the way up. You'll also, we're going to talk about runner's hip in a minute. That's IT band syndrome, where it'll rub on this knob. But again, tight IT band happening there. And then one that's not in this PowerPoint that totally should be is jumper's knee. And jumper's knee, I'm just going to mention this, even though it's not in the PowerPoint here, is where you'll get pain at the very bottom of your kneecap. And so when you hear someone describe like they feel like a lot of pain right down here underneath their kneecap, we call that jumper's knee. It's very common in basketball players, like super common in basketball players, and it often happens because of like tight quadricep muscles. And basically what's happening, I mean, this is going to show you like a full rupture, don't worry about that. But basically this patellar tendon right here that's supposed to run over top of the kneecap and insert, it just gets really tight. And so it starts rubbing on the very, very bottom, this sort of sharp part of the kneecap right there. And so you'll get patellar tendonitis, AKA jumper's knee. So like I said, that was caused by tight quadriceps. So what do you think this next slide is going to say? Oh, wait, that's right. The causes. It's going to say ensure proper range of motion and then proper strengthening. So patellofemoral pain, like I said, either transverse or like frontal plane movement. So where do we get a lot of these from? Like what's causing some of this, that poor patellar tracking? Well, sometimes it can be caused by excessive like knee valgus. That's one of our biggest things that we're going to look for, right? Oh yeah, and then there's some statistics here. Actually, really quickly before I move on to like what's causing these things. ACL injuries. This statistic right here, guys, I've seen this on test questions before in the corrective book. I think they put this in both the corrective. You're going to have it on, I think, homework 4. I think there's going to be a question that's like how many, what percentage of ACL injuries are non-contact. I've seen that question show up in the corrective exercise tests as well, because a lot of this information, this chapter here is like one tiny chapter of what the whole corrective exercise book is really all about. And I've seen the statistics, so I don't know. You don't need it necessarily right now, but maybe log this information away as like important, so that if when you hear about it again, when you get into capstone, you'll be like, oh, right, Brad mentioned that, and then put it in your notes. But ACL injuries, up to 75% of them are non-contact. That, I mean, again, whenever I say non-contact, what I mean is like completely preventable, should not have happened if we moved the way we're supposed to move, you know? Injuries, injuries that like shouldn't have happened, but they did because we have tight muscles, you know? And usually they happen from planting and cutting, sometimes with like a straight knee landing. So what are our risk factors for all of these? Well, one of the biggest ones is excessive knee valgus, right? When we see way too much of a Q angle. So remember, knee valgus is our big fancy way of saying a client who's experiencing like knock need, right? They've got their knees caving in. And you can even see there's way too much gap here, right? This ligament is way stretched out. It's used to being stretched out. This ligament over here is used to being short. So when you hit the knee from the side, you're going to tear either that LCL, or maybe you're going to rotate, and that rotation is an already stretched out ACL ligament, and then sure enough, like you over rotate it, and it tears. So when you see a client whose knees are caving in, that's that excessive knee valgus. They've got way too much of a Q angle, right? And then there's also bow-legged, which is, like I said, this is much less common. That's knee varus. Sometimes you'll see people who have that. So that can be a risk factor for ACL injuries. And then one weird one that we do have to mention, sometimes hormonally, that can actually be a cause of an ACL injury, particularly in women. We will see like female athletes who, are excessively low body weight or excessively low body fat percentage, will often produce less estrogen, and that lack of estrogen can actually like eat away metabolically at certain tissues of the body and actually be a risk factor for creating like more cortisol and things like that, and it can actually like put you at a risk factor for an ACL injury. Kind of a weird one. So how do we prevent all this stuff? Well, again, ensure proper range of motion and stabilization of your knee complex. So this is where we really get into a lot of talking about stability as well, right? Again, going back to that idea of like doing lots of like balance exercises where you are strengthening and like working on the bottom of the foot, working on recruiting your glute, working on stabilizing the knee. Those are all going to be really important. But also, like, obviously we like weight-bearing exercises that are going to target these overactive, underactive muscles. If your knees cave in, well, dude, strengthen the muscles that are going to pull your knees back out. If your adductors are pulling so much that your abductors can't contract, stretch out your adductors, strengthen your abductors. We need to be doing, that adductor stretch as often as possible. We need to be doing those medial glute strengthening exercises as much as possible. And so, weight-bearing exercises for that whole area are going to be really important. Lots of squats, get better at hip extension. Correct any faulty movement patterns that we do happen to see. If we see our clients moving with knee, squatting with knees caving in, we got to find a way to fix that. Feet turning out, whatever. Perform stabilization and balance exercises in particular, because those are going to be the best exercises to teach their bodies like how to recruit the right muscles. There's a reason we do that 4-2-1 tempo in stabilization, because again, stabilization is all about learning how to resist unwanted movement. And also, like, that's 7 seconds per rep. If you're spending that much time per repetition, that's plenty of time for your body, your brain, to learn how to do these specific movements. So that's going to be huge. And then obviously strengthening your entire lumbopelvic hip complex. Core strength is going to help with your knee injuries. I know it doesn't seem like much, but like that proper core strength is going to lead to proper movement patterns. Proper movement patterns are going to lead to proper like motion, right? Again, the most common one is going to be knees caving in. Like I said, you'll sometimes see knees cave out, but it's fairly rare. Oh, excuse me. Questions on knee stuff? Robert, Charlie, feeling good about the knees?
Yeah, I got a quick question, but it has nothing to do with knee injury, though, really quick.
That's fine.
Since you brought up the Q angle, last time you said when we do like an overhead squat, you can't technically tell how far someone's arms fall forward unless you get out the
protractor.
Yeah, the protractor. But as far as like with the Q angle, that's something that you actually can tell without getting out a protractor, right? Even though it's part of an assessment still.
You can tell it's altered in the same way that an arms fall forward. You're like, okay, well, that's definitely not the angle I want. But without a protractor, you can't be like 16 degrees, You can't tell how many degrees it is without a protractor. That's what I said about the arms. You can tell that the arms are falling forward without a protractor. You just can't tell like how many degrees they're falling forward.
Right.
That's why the overhead squat is still considered an objective assessment. Normally, objective assessments are very number based, right? number of pounds, body fat percentage, so, inches, whatever. So many objective pieces of data are based on numbers. But, when we're doing the overhead squat, it's like, I'm not measuring how many degrees your knee caves in, but I can tell that it's off. But if I were to get a protractor, I'd be like, oh my gosh, you're caving in by, 16 degrees. So that's what we mean when we say that.
So you wouldn't need a protractor to notice a Q angle, though, right?
No, because the Q angle is messed up.
Yeah.
Let's see here. Q. So we want it around 15, right? But if it's any higher than that, right? If it's like 20 degrees, you can see like that's a much sharper angle because the knees are caving in. Or it's like a dead angle because the knees are caving out, Let's see if I can find, let's see if I can give an example. Let's see if I can find a 0 degree Q angle. Probably not. That'd be like the most bow-leggedy person ever. It'd just basically be like flat on. Yeah. Okay, well, that's intense. This is somebody probably born with rickets or something. But yeah, that's some pretty excessive cave in, right? So that's what we're talking about with that Q angle there. I want to find a more extreme example. I like the extreme examples. I'm not quite getting it. Come on. No, okay. Well, anyway, yeah, it's what we're seeing here. That's the knees are like caved in, right? In this version, right? Flat on, caved in, bow-legged. But yes, you could get a protractor, or you could just eyeball it. Does that answer your question?
Yeah, it does.
Okay. So next area, the most commonly, it's so funny because it's like the lateral ankle sprain is the most common like injury. But in terms of like chronic pain that people deal with, 80% of people are going to have some type of low back injury. It is so freaking common. And low back injuries are huge. They affect about 6 to 15% of athletes. That's actually a fairly low percentage. But again, athletes are athletes, so they often have relatively strong cores, but not always. Or maybe they have a strong core, but they just play a really hard sport, and so it is still going to happen no matter what. So what we're going to see things like disc injuries, like herniations, slips or tears. Those are all exactly the same thing. Muscle strains, which are sort of the most common. Sacroiliac dysfunction, aka SI joint pain. So where your sacrum's coming together with your pelvis, if that gets very immobile. And so, a disc injury, when I talk about like a herniated disc. So herniated is not something that only happens in the discs. Herniation is just a general medical term that describes like a tearing in the lining of something where something else starts leaking through it. So your body is like all of these like wrappers, it's like a wrapper holding this stuff in, and there's another layer of like a wrapper that's holding all that stuff in. You're wrapped in fascia and in tissue and all this different stuff. But a hernia is where maybe you tear that lining, you tear that wrapper, and so something starts like leaking through. In this case, we're seeing it happen in like one of your spinal discs, right? So in between each of your discs, if you tear that lining, this material starts leaking out and it starts pinching these nerves here against the bone. That's why herniated discs are so painful. This what's called nuclear pulposus starts leaking out, and it starts like pressing on the bone there, and then like that nerve is being touched, which is tripping it, and so it's creating like a pain sensation, and decreasing your proprioception and all kinds of other stuff. So that's the very common one with, and it happens from excessive like movement of the spine. If your spine experiences like excessive compression or torsion or anything, it can cause that tear. So we get really nervous about stuff like that, right? We're also going to see like muscle strains, you know, like maybe just like straining a muscle or another, which can cause like a back spasm. I think that's what Lamar Jackson was dealing with last night. Did you guys see the Ravens Browns game last night? I didn't see it, but I watched like some of the highlights. And like during the highlights, like Lamar like goes out in I think the fourth quarter, and he was like cramping up, and I'm pretty sure it was his back that was cramping up, but I don't know, maybe it was his legs. It's usually the legs, but it looked to me like he was a little stiff in the core. But you'll see like muscle strains and muscle ligament, you know, tears and things like that, and it'll happen sometimes when like you get like a back spasm. That usually occurs because like proper movement doesn't occur, and so then you overstretch something, and then your nervous system goes, whoa, overstretch, and so then it, oh no, someone's cooking downstairs. Here, I'm gonna mute myself. Okay, can you guys hear me? And we're back. Cool. All right. Freaking thing. Happens around here a lot. I'm actually shocked that it doesn't happen during class more often. Like I set that thing off constantly. All right. So excessive range of motion that can cause like a strain, and then your nervous system's like overstretched, and so it starts spazzing as a pull in the opposite direction. Sacroiliac dysfunction. So I look at like sacroiliac. So your SI joint, your sacroiliac joint, is the joint where your sacrum is coming together to hold the two parts of your pelvis attached at the top there. And so when we see like sacroiliac dysfunction, what we'll often see is pain in this area of the low back, like right in here, right? It's often where like your L5 is sort of meeting the very top of your sacrum. We're seeing like a lack of mobility in here. Look at all this fascia. You can see like all this webbing is there to like hold this whole area in place. This is supposed to only be like a semi-movable joint. This is not supposed to be a super mobile joint, but when you lose any of that range of motion, it has a pretty detrimental effect. You know, what you'll often see is what's called a Trendelenburg walk. Let me see if I can show you what that is. Trendelenburg gait. It's basically this kind of like sexy walk. I mean, this is like a very, you know, kind of waddly version of that. But you'll see like basically they cannot rotate their pelvis side to side. So you'll see there's like a lot of like lateral movements instead. And so someone will walk kind of like this, where they're doing like a lot of side to side movement. Or if you notice, like see like a big hip drop. So you'll sometimes see people do this, like it almost looks like an exaggerated, like I said, like sexy walk, where they do like this kind of thing, where they're kind of kicking their hip out to the side. And it's like, you know, kind of a weird like movement there. But that's a sign that their pelvis is not rotating this way the way it should be, or like moving laterally this way. It's all locked together. So instead, the entire pelvis is either moving like this, and that's taking their spine with them, or it's moving like this, and it's taking their spine with them. And that's lost, by the way. That's caused by like a lack of, I think, like 3 to 5 degrees of motion. Very little movement, and yet huge consequences. So that often comes from decreased stability as well. One of the best ways to enhance that stability is simply to learn the drawing maneuver. Just suck that belly button in towards your spine, and that actually creates like a little bit of stability, and has a huge positive effect on sacroiliac dysfunction. If you have a client who has SI joint pain, they need to work on pulling that belly button towards their spine all the time. I used to tell my clients this: practice pulling your belly button towards your spine while you're at red lights. Anytime you're stuck at a red light, pull that belly button in, and you can relax and drive, pull that belly button in. And it's just going to really help. Because what that does is that activates your stabilizing transverse abdominis. It activates that whole stabilization system. So strengthen, again, I know I know it sounds so silly because we're just repeating the same thing over and over again, but that is the answer, right? It's flexibility for your overactive muscles. If you see someone who is an excessive forward leaner, right? And we know that it's like not because of the calves, and it's being caused by tight hip flexors, tight abdominals, and it's being caused by weak low back and glute muscles. So we got to get that person to strengthen and pull them back upright. Flexibility for the overactive stuff, strengthening for the underactive stuff, and then neuromuscular control and core stability. So lots of core exercises that are focused on core stabilization. I want to show you really quick. I know I talk about it all the time, but one of my favorite, protocols is based off of this famous physical therapist. His name is Dr. Stuart McGill, and he kind of wrote the book on like developing core stability. Oh my God, love that. That's so stupid. I love cheesy stuff like that, like lifting a log over here. That's so dumb, but I'm into it. So you can see here, like talking about like strengthening. I forget. Squat University, you always lose the eyeballs in. It's the worst. This is a great video. Squat University. It's a YouTube channel. I really recommend everybody subscribe to. I think this is his name's Aaron Horshig. He's a physical therapist. Absolute rock star. Absolute, totally focused on proper movement over just going through the motions. He's a great trainer, but you can see what he's going to do. He's placed his hands on his lower back. That's really just to create stability. They act as sort of like, I think he says like pressure sensors, which is a great way to describe it. And basically, like if you push, remember that from the assessments day, we mentioned that Sorensen, not the Sorensen erector spinae, the double leg lowering test, where you use the blood pressure cuff under the low back, and then all of a sudden, if you see the blood pressure cuff like spike, and it's like that's where they start pressing their low back into the ground. That's kind of what your hands are doing here. You're going to press your hands back there. You really shouldn't feel too much pressure on the hands. If any point you feel like a lot of pressure, you're crunching too high. But you'll notice, like, look at how very little he's lifting himself up off the ground. He's barely coming up during this crunch, right? He starts on the floor, and he just lifts himself up a couple inches. And, he's keeping his head in a neutral position. He's not reaching with his neck or anything like that. That's creating a little bit of resistance down this way. And that is a great exercise to strengthen your transverse abdominis. I like this over the plank a lot of times. The plank gets your glutes involved. So I love the plank, but a lot of times like people can't plank properly, and they'll focus on like recruiting the long thing. So I will often start with, this is called the McGill sit-up. And one thing you can't see because the camera's kind of punched in here, but you can see his other leg. He's gonna do it somewhere around here. Your other leg, you want to, not crunches. He's going to extend his one leg out, and that's just going to take some of the pressure off the low back. You don't 100% have to do that. If your client doesn't have problems with like overall core stability, but like if they have a herniated disc, sometimes stretching one leg out can have a really positive effect. So he's got one leg fully extended, one leg is bent, hands under the low back, and he's just going to crunch up ever so slightly. The next one is going to be doing like a side plank. That's going to resist, that's going to teach you how to create resistibility from the side motions. So doing a side plank in both directions. So you can do this on your knees. That's where you start. If your client can't handle that, or if they can handle that, then you can take them all the way up to the hands. And you'll notice he's doing a split stance here. Top leg is in front, bottom leg is in the back. If you want to stack it, that'll add some more instability, but this gives him more surface area, so it makes it a little easier. So that is, and he's in a straight position here, right? All the way straight from top to bottom. rather than like dipping or sagging or anything like that, or overhyping. And then lastly, you're going to do this bird dog movement. And bird dogs are going to resist you down this way. This is for the low back. So he's going to drive, he's going to be on one hand and one knee. He's going to drive his opposite arm and opposite leg. So, you know, in this case, he's got his right knee and his left hand down. He's going to extend with his left leg and right arm, creating a nice straight line there, you know, just like this. And that's the thing, you'll notice he's saying, don't go all the way up here, go straight. That's where we want to be. And the same thing is true with the arms. You don't need to be way up here, you know, over hyperextending or anything like that. You just want to have a nice straight line. So that's the McGill Big Three. He talks about doing this before every workout. Like, he's such a big fan of it. I don't know. That's a lot. But like, if you got a client with low back pain, this is one of my overall favorite programs to fix that. It's great for developing that overall neuromuscular control. And lastly, on our list, we've got shoulder pain. Shoulder pain is so freaking expensive just because the shoulder is just hard to get into, and so surgeons charge more for it. Occurs in about 21% of the general population. The two most common are going to be shoulder impingement and full-on shoulder dislocations. Shoulder dislocations are usually a contact injury. You know, they're usually like a traumatic event. But when we see like a shoulder impingement, I want you to think of, you know, when you hear the word impingement, I want you to think impingement. You know, and so what we'll see is basically due to poor posture, we'll see a pinching of these soft tissues in between these hard tissues, you know, and so that causes pain. That's going to cause, like, you know, tendons to maybe be rubbing on this hard tissue. That's going to cause inflammation. You might get shoulder tendonitis. You know, those are going to be very, very common there. And it's caused by, like, you know, improper movement. So shoulder impingement is repetitive compression of what is called your subacromial structures. It's just all this soft tissue underneath this, what's called your acromion process. So it's underneath acromial process, right? So we see like a lot of like compression in these soft tissues getting pinched between hard tissues. And then we're going to see we're going to see shoulder instability. That's another one, right? Shoulder instability is obviously going to lead to altered movements because you're not stabilizing your shoulder the way you're supposed to. So then you're moving your shoulder improperly. That improper movement can cause like pinching or pain, or, you know, I always tell people this, I've never had a client hurt their shoulder in the gym ever, but I've had a million clients, you know, reach for a sweatshirt in the back seat and all of a sudden, ow, you know, like something happened. And that's what led to some type of injury, or, you know, reaching for something overhead. That's where people are gardening. That's where people hurt themselves. So a lot of times we know that this is being caused where we see like improper posture. We see a lot of shoulder rounding. You know, we see like a lot of excessive cervical and thoracic flexion, or protraction of the shoulders, or internal rotation of the shoulders. All of those are bad movements, right? So we need to focus on thoracic extension, we need to focus on retraction, and we need to focus on external rotation. All of those are going to have positive effects when it comes to strengthening. So we're going to perform corrective exercise on our overactive and underactive muscles again. And particularly, we're going to spend a lot of time focusing on like rotator cuff strengthening and stabilization. We're going to do a lot of external rotation movements, you know, grabbing onto a resistance band and just pulling that arm out. I'm showing my hand up here. You would want to have it level. But external rotator strength, and then scapular strength, right? Focusing on like strengthening, you know, if we're supposed to do that protraction, not doing it from the pec minor, but doing it from that serratus anterior, you know, learning how to do like a proper push-up plus, use that serratus anterior the way we're supposed to, so we can get that tilt of the scapula to stop happening, you know, start pulling that scapula from the bottom while we're also pulling it from the top and the back, you know, strengthening that middle and lower trapezius, getting us to stop being in this tilted position, getting us back upright. So that's what we're looking for in like our shoulder injuries. This textbook doesn't really cover cervical injuries. Unfortunately, it doesn't really go into the neck. But obviously like forward head posture, elevated shoulders, those are also going to be big things that cause like a lot of issues and a lot of aches and pains. You'll cover more of those in corrective exercise. But again, like, if you see a client with forward head posture, that's going to further round their shoulders over because that weight's all coming forward. So we need that, proper extensibility of that sternocleidomastoid. We need to strengthen those lower trapezius muscles and get us back into that upright neutral position. So it's kind of funny. I mean, this is all about injuries. I like to think of this as almost this chapter as really just like injury vocab, because like, you don't need to know what injury someone has to look at them and see like poor posture and be like, and for them to be like, yeah, I have this injury and I don't really know what caused it. And it's like, yeah, I mean, I can look at your posture is what caused it. And it's like, I don't know, like specifically what happened the day of the event, what little micro tears you experienced or anything like that. But like, I can look at you and say like, oh, I mean, I know that like when someone has a posture like yours, it often results in these common injuries. And so, it's not that you did anything magical. You have to avoid exercising. It's that you need to fix your posture, and that stuff's going to go away naturally on its own. It's so funny. We live in, I was like ranting about this the other day. But we live in this world where like a lot of times we want like a very simple answer. We want like a simple but interesting answer to why our problems are the way they are, when you look at an injury, like our stories are all based around like, the silver bullet. It's the one thing that can kill a werewolf, right? A stake through the heart. It's the one thing that can kill a vampire. I guess some might, but but you're telling me like if I took a vampire and like dropped a freaking nuclear bomb on them, that wouldn't kill them, like, or if I like dropped them in a blending machine, like, and like blended them into goo, like, we like these, like, we've a lot of our fiction, a lot of our stories that we kind of tell ourselves, it's like there's this one magic thing that broke something and there's one magic thing that'll fix it. If I buy this piece of training equipment, that'll strengthen my core enough, or if I do this, it'll be the magic thing that fixes everything. And it's like the real answer is it's like years of bad posture and this decision plus that decision plus this one, like years of that led to only one thing happening, which is this injury. And unfortunately the road back from it is this plus this plus this plus this, and a lot of hard work and time. And nobody ever wants to hear that. They're like, no, give me a pill. Like, give me like a thing that I can take that'll fix my shoulder. It's like, it just doesn't work that way. Hold on, actually, do you guys have any questions? And I'll after the recording, I'll play a video and I'll show you what I mean. Do you guys have any questions about any injuries today? Anything like that we covered? Feeling good, Robert?
All good. It helped me from my question yesterday. So.
What's that?
Going over all this was it gave me more insight from my question.
Right? Isn't that so funny? Did I say that last night? I was like, we're gonna talk about this tomorrow. Yeah, that's so funny.
I should have waited for that question for today. It would have,
Nah, you're good. I'm just glad to have the question. Let's see your tongue here. All right, yeah, check us out. Hold on. I gotta find the right one. Oh no, it's not the right one. Oh wait, I'm still on the recording. All right, ending the recording. See you all tomorrow. Whoops.